Zero started. And so, I mean, I was taking a look at the PowerPoint from the text, from the Cowan text. There's some stuff I'm going to buzz through that later. Maybe not today, maybe Friday. But really, our focus is going to be on lower respiratory infections and the different kinds of pneumonia. Because if you're in a clinical environment, as many of you are going to end up at, you see a ton of this. It is extraordinarily common diagnosis. Again, you can't emphasize it enough that this is, by any standard, the fourth largest killer. I mean, the largest killer by way of infectious disease in this country. That's not worldwide, but it is in this country. So this is really the big event because people in the hospital are very prone to it. The very old are very prone to it. It's the aftermath of viral infections. Viral pneumonias certainly pave the pathway, so to speak, for bacterial pneumonias, which are they cause a much more extraordinary amount of damage. So, all that aside, this is what you think about. And if you're going to be in a clinical, for this one thing, we used to keep people overnight all the time, and you would look for things. That's when you always did the temps every shift. You know, the temps were done every shift, and you had the neat little kind of clipboard at the foot of the bed in the old days before everything went digital. And you'd map it out, all the vital signs, and you'd look for what we call a spike. And the term spike to fever was really indicative of one of two things, typically pneumonia or potentially a blood clot. Because we would have people in the hospital for long periods of time. Even I did for comparatively minor procedures. I mean, you're night before, day of the surgery, 2 days in discharge for 2 days, like a four-night admission, 3 to 4 night admission. It's totally changed today, I think just because of the expense. But nevertheless, this is one of the things, fever, all of these things, any or all of these, cough, chills, shortness of breath, fever, chest pain, sometimes you'll begin to see that sort of cyanotic kind of discoloration, sort of just all of a sudden their color doesn't look right. It's a little bit on the bluish side. And we look for a productive sputum. And really, with the changes in that, and as much as it's kind of gross to think about it, we look at the color of the sputum because it gives you an indicator, and it's all about that thing you did in lab called hemolysis. Okay? If it's partially hemolytic, it has sort of a rusty or brownish color. That's indicative of Streptococcus pneumonia, by far and away the most common. You're going to see one that you see a lot in the hospital, and it's not a good diagnosis. I mean, that usually has a pretty high incidence of people not surviving. It's called Klebsiella pneumonia, which is contamination with a colon, a gut bacteria that comes from incontinence, catheters, etc., all of those types of things. Then it becomes almost a cherry red kind of a sputum. It's not hemolytic, but it does a lot of damage. It does a tremendous amount of damage to the linings in the lung, and there's a lot of bleeding, the blood vessels. You know, basically, the sputum is soaking up regular blood. And then when you see tuberculosis, it's kind of a swirl. Okay, it's almost like a swirl pattern, where we begin to see evidence of sort of green and then red. Again, we're always looking for those changes that are there. And that's why we look at sputum when people bring up. We want to take a look and do sputum cultures. When you're looking for tuberculosis, that's where you do you'll see the thing on the chart. Sputum culture for AFB, acid fast bacilli. You did that in lab when you were looking at mycobacteria. Just that kind of a thing. And really, you have to look at them microscopically as well, and then find out what the appropriate antibiotics. You'll learn about the sounds that are there. You can hear you listen for breathing sounds. They're just not there. You can almost sense the fluid that's there. And they'll discuss things like rhonchi and rails, and that's not for this course. And certainly chest x-rays are indicative because what it looks like is it's almost like normally a lung should be clear. You should be able to see right through it. So on an x-ray, which is kind of like a negative from an old photograph, the bones are white because they absorb the radiation. The background is black because it goes right through it. And so what happens here, it isn't black. It's almost kind of like a snowstorm. It's very, very foggy kind of a picture. And that's because of the density of the fluid that's in there. It doesn't allow the x-rays to pass through the same way it was filled with air. That's the whole idea when we look at radiographic studies and things like that. And so you start to become familiar with those things when you see the report, things like that, when you see them on a chart or you see them, however, the charts, the electronic nature of charts today, with which I am not familiar. So it can often be caused by opportunities, things that are normal. Most of the time, the mucociliary escalator, all those wonderful ciliated, pseudostratified columnar epithelia are damaged. Mucus is being produced. Capsule is a common denominator. You're going to see this with several of these. Typically, the inflammatory response, and it doesn't have to be a rocket scientist to know, if you fill the area where we're trying to exchange oxygen and carbon dioxide, did you just do the test had respiratory in it? Oxygen and carbon dioxide, if something gets in the way, they don't move very efficiently. And that's the problem with pneumonia, okay? So you can't effectively deal with the exchange of oxygen and carbon dioxide. And over time, it consolidates, thickens, clogs, pain associated with it. Yuck. You don't want to have it. If you ever had one of those really deep chest colds or bronchitis and like, oh, really big bad case of influenza, which is one of the topics we probably will get to more likely Friday, it is not pleasant. It takes a lot out of you. Breathing should be effortless. We have to struggle to breathe. It fatigues you. It's like struggling to walk. Walking should be, relatively speaking, effortless. You have to struggle to do that. You compensate and use different muscles. Just think the last time you had sprained an ankle or stubbed a toe really bad. You compensate, and all of a sudden, why am I getting so tired? Same thing with this. That's why I'm trying, at this stage of your careers and this early stage of your career, I'm trying to give you some ideas of how to put things together. Try to see that larger picture. These are the kinds of little things that people tell you. What's different in your activities? What are the problems? I am more fatigued. I'm tired. So if you get a young, healthy individual say, I don't know why I'm so tired. My back's hurting. You've got it. That's a whole diagnostic process. Something is wrong here. What can we relate it to? That's why maybe the single most important thing that anybody in a clinical setting does is they get a history. I know, because sometimes it's obvious. Okay, you got a great big cut because you were in an accident. Okay, I can see what's causing the bleeding. But no, it's not often that easy. And so I'm iffy about the vaccines. They're only recommended for people probably 60 and older. I said thanks, but no thanks many years ago. What my family doctor said, it struck me as yet another vaccine for someone who at that point was still fairly healthy, having stopped smoking by the time he offered it to me. I wasn't too worried about it. Okay, but it covers a lot of strains of pneumococcal diseases, and that's Streptococcus pneumoniae. So here it is. 60% of adult community acquired, means not in the hospital, patients that eventually require hospitalization, Streptococcus pneumoniae. Forever, it was easy to treat with some kind of penicillin if they weren't allergic to penicillin. Bad news, we're starting to see increased degrees of resistance, and it's only increasing. So what the current therapeutics are, I can't tell you. I'm sure you're going to find out. But unfortunately, the increasing resistance to penicillin in members of that family is not a good thing. Cough, fever, chest pain, just all that same stuff you heard before. Relatively short incubation period, doesn't take long. Okay, and these are the little things. It starts off, running and congestion. The next thing, fever and chills. That's your body's immune system fighting it. Fever and chills, you're alternating by bursts of immunological products that are causing you either increasing the heat, so you're shivering, okay, and you have fever, and they wane for a while before they're released again, and then you get chills. It's a very interesting combination. Again, rust colored, pinkish, it's not red. The blood is starting, the hemoglobin is starting to break down. That's what hemolysis is. It's not complete, it is partial. That's very significant. Okay? Hurts like anything to breathe, poor oxygenation, sweat heavily, return to normal temperature after 7 to 10 days, assuming they survive. So imagine back before the era of antibiosis, before we had any of these agents, it was very touch and go. I mean, you were just trying to keep people going if at all possible. Very, very difficult. So I remember either reading an article or reading a paper about all these significant discoveries in medicine, like Pasteur, that kind of thing, or the development of X-rays, or the start of antibiotics, or the beginning of molecular biology, and things like that. There's certain seminal events, and I mean, this is antibiotics are certainly one of those with regard to the overall wellness that we have been able to achieve with modern science and more modern medicine. We're only talking about antibiotics that haven't been around for 100 years yet. So here it is, strep pneumonia. These are cocci in chains. I know they're not like perfect little circles. Staphylococcus have really nice circles. Okay. Streptococcus, a little larger, a little more irregular shape. Not quite coffee beans, that's another shape. Okay. You see lancet shape, and it's got like a little point on it sometimes. Typically, where they attach. That are there. And not that you have to know any of that. Capsule. Remember, I sent this when we did that take-home unit and that exam with conjugation, transformation, transduction. Basically, this is a famous study that was done when I did that unit, and hopefully you listened to it, where they began to study. This was what Griffith did in 1920 or 25 before antibiotics. He realized that the encapsulated Streptococcus pneumonia was a killer, and he realized that the non-encapsulated form was not. He was testing it on mice. And then he discovered transformation because he took the heat-killed encapsulated one, combined it with the non-encapsulated one. Go back and listen to it, where you'll see it within our textbook. It was on chapter 8 on either Cowan or the Nestor textbook, and you'll see the experiment. And that's how he found out that from dead bacteria you could have these little genetic units that could basically move from point A to point B. So the capsule did not cause the invasive disease. There's lots of different types. Okay, 90 different serotypes, each with different antigens. That's why it's not so easy with this pneumonia shot. I mean, yeah, you're going to get the common ones, but if they mutate or things like that. And that's what I mean by like a snowstorm. Here's a clear chest x-ray. That's normal. That's the shadow of the heart. It should be less than half the girth of the lungs for a little elementary radiology for everybody here. But you can see that whole side is, and notice on the right. Remember, I told you about rights are more common than left because of the anatomy of it. You never know a right from a left, but it's the heart shadow that gives this away. Why it's a right. If you didn't know, when you see x-rays, they will always have, particularly if it's something that is an extremity or you're looking, distinguishing between right or left, there will typically be a marker with either an R or an L, because you can flip them around. And it kind of looks the same that were there. Okay, and so there's a lot of different things. These are some of the agents that damage it, which you don't have to know. The accumulations in the alveoli caused by a lot of these factors basically change that sputum. Okay, the pneumococci, and understand the big problem when it's a kidney infection, whether it's a lung infection, is the proximity of your circulation. You did this in lab, in A&P. You looked at a lung. All the lung is a bunch of air passageways and membranes and blood vessels. So wherever the air is, the blood vessels next to it. It's a little sandwich. Here's the membrane. Here's the capillaries with the oxygen, pick up the carbon dioxide. Here's the blood. If this damages it on one side or the other side, the infection is going to tear that apart. It'll be like a giant opening, and effectively, that's the way it goes through your system. Same thing with the kidney. It's just membranes. If they're damaged at all, it basically spreads it rather easily throughout the body. So all of these things are there, enter the bloodstream. If the heart valve is damaged, like a heart murmur, endocarditis, talked about that a little bit before, meningitis, not a good thing. In several days, antibodies allow phagocytosis and destruction of pneumococci and recovery, assuming none of this bad stuff happened. So unfortunately, a lot of this is in elderly people. I mean, you may all want to be. I find that most students, I'm painting with a broad brush. Most students don't come in with the idea, I want to go into gerontology. I want to deal with older people. You're going to have to get used to it to start because older and sick people is who you're going to run into. You know, fascination with pediatrics or oncology or whatever you want to go into, that's not something you necessarily see right away. You always have to learn from the nuts and bolts of what's going on. And this is one of the things that you come in contact with. So you need to start being familiar with what you're going to be exposed to initially on a typical, let's say, med surg floor. For some of you going into nursing, it's not so exciting just yet. So up to 30% of us carry this. Hello. Okay. Risk of infection increases when it's impaired. Pick a reason. Diseases, diabetes, cancer, that smoking thing again. Okay. Resistant strains, much more common. And they give you the numbers that are here and the vaccine for the 23 most common pneumococcal strains. Okay. So, I mean, that's a decision that people make with regard to them. Okay. So don't be judgmental because someone didn't want to have a vaccine. Because they will all, anybody, particularly older people, will tell you, I remember my neighbor, my friend, my brother-in-law had a terrible reaction. And that's the reality of it. They're not innocent. So there's risk with anything that you do that we consider invasive. Invasive means you're giving somebody a shot. It's invasive. So there's nothing, it's not without complications. Tetanus shot, same deal. Not saying not to get them, but understand what people may or may not be thinking. Klebsiella pneumonia is nasty. We see this. This is much more common as a hospital-acquired illness. Okay, Klebsiella, mostly when we say enterobacteria, those are colon, gut bacteria. Inevitably, they came from patients who are either incontinent or partially incontinent. It's associated with catheters because of the proximity that's there. It's easy. When a patient has something like that, you're not watching them 24/7. Does anything else doesn't feel right. How many times you touch yourself and all these different things? It gets in your hands, it gets on your face. 5,000 to 8,000 times a day we touch our face to inhale it. There it is. You know, they're not so, and it's not their fault. But this causes most of the deaths from HAIs, healthcare associated infections. Same deal. Okay? Most symptoms similar, but it's a lot more severe. And you get this, the jelly-like, and it's typically, the old days it was like a cherry jelly. And these have illustrations that they might still have it someplace. But it's pretty yucky looking. And here they're showing you some of the mucus that's there. This would not be Klebs. If it is, then it's probably not as good of an illustration. So the big idea with, and Klebsiella pneumonia is relatively innocent other. When I was doing the lab, I had Mrs. Maurer, who orders all the stuff, runs all the labs. And some of you may have her for lab if you have it, this afternoon. I had her order Klebsiella pneumonia and did that as one of the unknowns, one of the panel of gram negatives. It's a cousin of Enterobacter. You guys work with Enterobacter aerogenes. Were you inoculating tubes this week? Yes. See, is Enterobacter one of them? E. coli, Enterobacter, Proteus vulgaris. See, I've seen this movie. I used to have Klebs and Salmonella typhimurium added to that list, like 6 of them. It's fun. Love that stuff. So it can be found all over the place. Okay, transmitted by contact or from medical equipment, ventilators included. Once they get in there, big trouble. They adhere very easily. There's a lot of these different things, a lot of these steel iron. Just as an aside, I'm not going to ask you about it. The big deal is it causes abscesses in the lung, meaning pockets of pus that destroy the tissue. And remember, when you destroy lung tissue, what's right next to it? What are you heavily going to destroy with it? Capillaries. It's going to bleed. And that's where the blood comes in. It's just a very destructive form of pneumonia, which is not necessarily the case with streptococcal pneumonia. Again, streptococcus pneumonia has 3 names. Use them all. So if someone says to you it's pneumococcus, streptococcus pneumonia, same thing, or diplococcus pneumonia. 3. They're just, it's like somebody has like a whole bunch of different names. Okay, they utilize. So widespread, commonly part of our normal microbes, very old, very young, compromised. And that's what you're going to run into. Most people go to the hospital are compromised. Nursing homes often resistant, increasingly becoming multi-drug resistant. That's where it's forming. Remember that word or that interesting acronym I gave you before? My kingdoms for my marker. I have it in my pocket. I do have it. ESBLs, those extended spectrum beta lactamases. Those are the resistant ones. This is one of those nasty old bugs. You really don't want to get too close to if you can help it. Okay. So increasing resistance. Here's the SBLs. Okay. Even some of these, I'm not going to ask you about carbaminomases, fewer choices. If you have one of these, oh my goodness, it's a 50% fatality rate. So depending on where you're going, you'll run into, and as you run into it, you're more using it. I don't know how much they're going to stress this in pharmacology. Surgically, no vaccine, a lot of very, very strict infection control procedures. Walking pneumonia. Mentioned it in passing, we talked about mycoplasma. Mycoplasma was one of those things that doesn't really have, even though it's a bacteria, it's got a very poor cell wall, and not a lot of peptidoglycan. Remember sterols? That's how it maintained its integrity. Has a variety of different shapes by definition called cleiform. Okay. This is the most common type you would see. If you go to the health center, you go to an urgent care, and they say, "Yeah, I really think you got walking pneumonia. You're not that sick, but you're sick." So you can still function, you can still go to school. Realistically, and that's where it got its term again from military recruits in the barracks and dormitories. I don't know, nor do I want to know what dormitories are like here. I've never been in one, and I have a certain inherent fear. I didn't even like being in a dormitory when I was in school. The last dormitory I saw was my son's at Duquesne when he matriculated there in 2001. Nearly a quarter of a century. That was the smallest room I've ever seen for 2 people. Like to put the beds together, you had to walk sideways to get through. Somehow the 2 guys stacked the beds. They were very clever, and put a couch on the other side. Your rooms are not that small, I take it? Yes, no? I mean, you can walk between the 2 beds? I'm a terrible roommate. Because I'll be up all night, not studying. At least I was in college. So someone says there's a party going on somewhere. Moving on. So this is the so-called walking pneumonia or atypical pneumonia. Is very easily treated, but not by penicillins, you might remember. This is something, the Z-Pak, erythromycin, fibromycin, which is tetracycline. The onset is more gradual, and the course takes longer. That's pretty consistent. Dry cough, maybe some ear problems. It's kind of funny the way these grow. This is that fried egg appearance. It's more difficult to grow than you think, so I wouldn't ask you about it. And if anything, that would be a lab question, if indeed they tried to cultivate it in lab. But that's a good illustration. So only a few cells, doesn't take a whole lot. So that's an infectious dose, it's very small. That's when you look at the epidemiology of it. Okay, inflammatory response, thickens the walls of bronchial tubes and alveoli. You can imagine that would be problematic, but we don't see it too much in older folks. So it's more of something you would be confronted with. Droplets, about 1/5 of bacterial pneumonia, so that's more common than you think. So if that's something someone here might have, may not even chose to seek treatment may not have. And it's not a fault necessarily. It's just in some people it's just not that severe. Repeated infections can be a problem. No, not it doesn't have an organized cell wall. I think it's a better way to say it. Macrolized, that's where the Z-Pak's from. Yeah, it's pretty hard when you're in a not this classroom today, since for those online only a handful are here. Okay, but typically if you get a typical classroom where, like, remember the first day of class we had all the people here. That's it. Pardon my humor. Whooping cough. That's a scary picture in and of itself. This is a bacterial infection that is defined as lower. This is DPT. Diphtheria, it's actually DTaP. D for diphtheria, T for tetanus, and what they call acellular pertussis. The one that is the hardest one to work with, and the reason why we see more pertussis by far and away than certainly diphtheria or tetanus, is the least effective of that trio of vaccines we all give at the same time. They've had to reformulate it, and for a while, maybe in the early 90s, I think we were just using DT, diphtheria and tetanus toxoids, because they were trying to reformulate. So the TAP, the A, little a, big P, is called acellular pertussis. Exactly how it's formulated, I don't know. That's not the purpose of this course. But it is still everywhere. A lot, where we see it more in this country, thankfully it's not, it's terrible in infants. This is one of those diseases that so frightening because the whoop is this, I can't duplicate it. I mean, it's a sound like you're trying to get air in. It's so like, it's almost like a loud, horrible sound. And I'm sure they would have, you could have an audio of it on somewhere online, easy to find. You know, some kind of teaching YouTube video, easy to find. And those kinds of things. And it's extraordinarily scary and it's a fairly high death rate for infants. Okay. We see it clinically in people with long-term chronic coughs. Toddlers, their parents, a lot of time they go to the doctor. I have had this cough for 6 months. I don't know why I can't get rid of it. And normally they're just saying take cough syrup, do this, allergy pills, whatever. And then they decide, well, let's do some additional tests. And they do some additional tests and they find out that actually it's a long-term chronic case of pertussis. Okay. Not acute, not life-threatening, just highly, highly annoying. So that's where you see it more. But you can see globally it's a big player and horrible for little ones. Catarrhal is a fancy word that means mucus production. So when you hear a catarrhal, that's an old term where mucous membranes, and it looks like a typical URI, runny nose, usual. And then paroxysmal means sudden, abrupt. Okay, and so all of a sudden, uncontrollable coughing for weeks, dry, blood vessels rupture in the eye, tongue, all the inhalation, that whoop sound, terrible things. And then you have the recovery if the individual survives. Much, much higher death rate in infants. And again, we don't see it here because it's one of the early vaccinations that's given, thankfully. I mean, that's, despite me drilling on about immunizations, that's one very, very successful. It's even in the convalescent stage, these chronic ones, it's really not contagious. Okay, it's a little gram-negative rod. It's just something that I think is particularly prone with infants more than anything else, or maybe their caregivers. It doesn't, again, it influences the ciliated area, mucus plugs. Chief cause of death is pneumonia due to this, or more commonly, another secondary bacterial infection. This is a bacteria. You can get a secondary pneumonia to it as well. Secondary means the primary infection from one can be a bacteria leading to another bacterial infection, a virus leading to a bacteria leading to a virus. Primary is the first one. Whatever follows it, if it's another infection due to that, is secondary. I suspect that's a question on this Blackboard test. Don't tell anybody who isn't here, doesn't listen. And again, it's another one of these AB toxins that are there. You don't have to go through what it does, tracheal cytotoxin or adenylate cyclase, etc., etc. But the A attaches and the B is the toxin, and they separate inside, and then all of a sudden now the active is what's causing all the damage. So again, the organism that causes this, because I zipped through it, Bordetella pertussis. Again, you're taking your dog like we do to Camp Bow Wow periodically to board or for daycare. Okay, they're going to require Bordetella because it's a common, not necessarily pertussis, but other strains of Bordetella, which are common in animals. And we hear about something called kennel cough. Contagious, respiratory secretions suspended in the air, particularly during that mucus phase. Typically, the fatalities, as you can see, are for infants, milder, maybe mistaken for another disease such as a cold, transmission, and a long time. And these are the other things that why we see it. Suboptimal vaccination, that's the part where they had to go reformulate it. Decreasing immunity, development of resistance, all of those things are part of it. And again, if you can get it soon enough, again, this response, macrolides are like the Z-Pack, various kinds of supportive therapy. Again, they changed it now. That's why we call that DTaP in there. You can even get additional boosters. Okay. And I think, I forget, they used to publish the death rate of someone who was unvaccinated, but it was fairly high. Oh, like diphtheria. We're talking about really substantial, even if you get to treat them, because remember, it's a toxin, and you really, we don't have the antitoxin to give them, per se. You're just trying to treat antibiotics so the body can deal with the toxins. That's a successful. This is sort of an interesting hybrid, and I'll frame it. TB is kind of an interesting discussion that are there, and I guess the way to frame it is TB is not, it's a bacterial infection that behaves like cancer. You saw that in bacterial pneumonia, it can get into the bloodstream and do damage, really bad things, and go off. Tuberculosis is like that. Tuberculosis starts in the lung, grows in the lung. It damages the lung to such an extent that the bacteria can be released into the bloodstream and spread everywhere in your body. It can go, it's got a fancy name, miliary, miliary. That means it's seeded everywhere, like the miller. You have an old mill and stuff like that and grind wheat into flour. And so that's where the miliary comes from. And what's interesting about that, it can go into the bone, it can go into the kidneys, it can go in the heart, go in the brain. Pick an organ, they can get tuberculosis. And when that happens, that person is most likely. Everybody has that. The name that they gave tuberculosis back in the old days, so maybe in one of your classes they ask you to read, like an English class, a novel from the 1800s. They'll have to say something like, so-and-so died of consumption. Along with measles, this is the poster child for research in diseases. I've been looking at the numbers recently, mostly coming out of urban areas. I've been studying in New York City. Oh my goodness, for the last 3 years, up, up, up. Not good. A disease that we thought we had. That was there. Decline in industrialized nations because of it's about overcrowding and living standards. I mean, if there's one thing, overcrowding. That's why, and I think I told you this, we don't use the immunization, but if you travel to certain countries where it's prone, I'm thinking India. India is a very, very large country. You're not getting in there unless you have this immunization, which really doesn't work particularly well in dogs. It's somewhat useful in children. Remember, I may have told you early on, if you recall, that my daughter had to have this. Which is the trouble why we don't use it. It makes TB screening useless. It's a cousin. It's called Mycobacterium bovis. This is Mycobacterium tuberculosis. So my daughter had that when she was an egg donor, and she went about 3 or 4 different times to do this because they do these procedures as it is, the people who are hopefully going to use these eggs so they can have them to have children, are paying an immense amount, literally hundreds of thousands of dollars. It's easier to do those procedures. You can do them in this country. So they paid for, obviously for her and a companion's plane fare. It's not easy. You're about 2 weeks, a whole lot of shots of stuff that you would be like, same kind of shots you'd be getting like if you're doing IVF. Feature fertilization, specific designed to stimulate multiple eggs. So it's a surgical procedure, not as invasive. I think it's an intravaginal rather than cutting in the abdominal cavity. So let's see. In 1985, the incidence began to rise because of AIDS, so immunosuppressive diseases started to increase. And again, we classify them based on their drug resistance. So this is what the CDC is trying to get off these plans. And effectively, is over time they have gotten a handle based on this chart. This is about 8 to 10-year-old information. So more recently, they're tracking it, and that chart is starting to go up, increasing. So that's the backstory for tuberculosis. Why is it so bad? Mycobacterium tuberculosis, the big factor is this capsule, the acid-fast capsule that you tried to stain in lab, which is a very difficult stain to do, okay, is the problem. The immune response controls, but is unable to eliminate it. And so a lot of people who are exposed to this develop what's called LTBI, latent tuberculosis. That can activate. There's a relatively high percentage. And when it does activate, this is another one where the big thing, night sweats. Night sweats is a big tell. We see it in cancer patients who are late stage. It's almost like the body, just like consumption, the cancer is spread and the body's being gobbled up from the inside. The same is true for tuberculosis. So, I mean, if when somebody, as chilly as it's been here, to wake up covered, soaked through with perspiration is not a good sign. Not a good sign at all. Weight loss, all this, the cough, the blood streaks is a very good way to describe it. They can travel through the bloodstream, going everywhere. I've seen it in bone in my own practice. This is that AFB or acid fast tape. Why do we do this? It's got a very, very long generation time. So growing it in culture would take 10 to 14 days. So that's why the acid fast test that we do is a quick way. We do sputum for AFB. And you can see it's relatively easily killed by pasteurization. That's not the problem. We're not dealing with so much on surfaces or in food. It's spread respiratorily. And again, it's airborne. It stays in the air. I commented on that before. What happens is, and you did respiratory, you're just telling me now, okay, the macrophages, you've got tons of them, millions and millions your body makes every day. Okay, in your respiratory, they're like little sweepers that gobble up everything. It gobbles up these very quickly, but I call it hiding in plain sight. It lives inside one of these macrophages. And your immune system doesn't get a clue until it starts to replicate and changes the markers on the cell. That's why it's cell-mediated immunity. That's why it takes, when you get a TB test, as many of you have gotten or will get, if you react right away, it's an allergy. You have to look 48 to 72 hours. That's called delayed reaction hypersensitivity. That's cell-mediated immunity. It grows inside the cell. It changes the markers on the cell. Did you talk about MHC1s and MHC2s? It's okay. Be happy you didn't have me for immunology. Maybe I can put that in. We can do immunology. Don't look at me like that. Okay. So what happens? It can't be inside the macrophage. It can't be gobbled up in a lysosome. It can't fuse. Okay. And they multiply within the cytoplasm. Okay. It develops an inflammatory response and more macrophages. And rather than being able to, it's almost like this. inside of a macrophage, growing, and all the other macrophages try to surround it. That's what forms what we call a giant cell. And we call it a granuloma because these cells, pardon me for this marker, quickly. Granuloma is cells that have granules. Remember when you learned about blood? I'm sure you did. You learned agranulocytes and agranulocytes. See, this is where this all comes together with A and P. And it forms this, what they call a giant cell. And what happens is it gets oil inside and it gets foamy and has a very interesting kind of material inside, undergoes a very interesting kind of death. Necrosis is death, and the name for this death is caseation necrosis. And it's kind of yucky and foamy, kind of like you had, think of having like milk in the fridge for too long and it kind of gets these lumpy things in it. That. I think anything that make you go, ugh, that would be this. Okay? Caseation necrosis. And what happens, these giant cells begin to firm up and harden. Eventually they calcify. And so when an anatomist would feel the lung in somebody who died, they think, oh, there's like bone in the lung. And what's our small little lumps of bone called? That's right, tubercles. Not trochanters, not tuberosities, not spines. Remember the tubercles, right? Is that a name you learned in lab? I know it. Channeling my Mr. Rogers. Can you say tubercle? I bet you can. And so that's the name tuberculosis. Got it? Now you got the saga. What happens, they begin to accumulate so much, they burst the blood vessels. This thing opens up, spits out all these cells, and they spread all over the body if it's not treated. Voila. So, and they're going through this whole thing, a Gone foci, or Gone complex, and blah, blah, blah. And so in many cases, the infection itself resolves, and that's latent. And if somebody's immune system is compromised, if they get older, if they get sick, if they have another disease, it can activate. Therein is the problem with tuberculosis. And so, and this is the thing, caseation necrosis, foamy macrophages, it releases, there's a cavity in the lung, so they call it a cavitating, C-A-V-I-T-A-T-I-N-G disease. The cavity persists, bacteria spread, coughing, bleh. So here you can see these cavities. They're there. Here's all, see all those, that's the boundary of the tubercle is here. These are all the white bloods that surround it. It's growing inside there. And they're trying to give you an idea from this diagram if you can get something out of it. So fortunately, look at this. This is 8 to 10 years ago. 13 million Americans have latent. Only 5 to 10% will reactivate and progress. Respiratory, very low infecting dose, crowding, coughing, immunodeficiency, AIDS particularly. Again, it's an AIDS-defining illness. And this is basically how you identify it. It's there. And we were very successful before in treating those who were necessary. And the problem with treatment, multiple drugs that you have to flip-flop. You have first and second, two categories of these. I don't want to go into those. Okay. And they're classified based on how severe it is, whether they're multi-drug resistant or extensively drug resistant. Because they're talking about resisting just first-line drugs and now first and second-line drugs and blah, 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 blah. Nasty. Okay? Really very challenging. This is the vaccine. BCG is a fancy name. You don't have to know. They always say BCG is called Bacille Calumet Guerin, 3 French scientists. It comes from Mycobacterium bovis, a similar one that affects cows but does not affect us. The immunotherapy that I had for my bladder cancer was this. They basically put in me M. bovis. It's very interesting. So we use it for immunotherapy now. But the vaccine just really doesn't work. Not in adults. And they're trying to work on that. Airborne is very critical. Stays in the air. That's why I told you about all the ventilation. So let's stop it here. We'll do a start with Legionnaire's disease on Friday. I'm confident we will finish Legionnaires and not a lot on anthrax, but flu. And basically, we're done after that. There's not a whole lot after all of this. Thank you.